Hello, I'm John Foster, and I'm a medical doctor who does Social Security disability exams. And today I'm going to talk about 6 common impossibilities in patients' history and physical exam that I see when doing disability exams. As usual, everything I say is based on my own experience and learning and does not reflect the opinions of the Social Security Administration or any other medical body. Now, why would the patient exhibit impossibilities in their history or physical exam? Well, there are several possibilities. Number 1, the patient may be mistaken. Number 2, the patient's doctor may be mistaken. Number 3, the patient may be manufacturing symptoms or signs, either consciously or unconsciously, and they have a functional illness. So let's talk about these 6 conditions I often hear patients complain of or display when they do not in reality have them. The first is the diagnosis of bipolar illness. I've previously mentioned that I think that psychiatry in America today is in a sorry state. I wish that when the DSM-6 comes out, they'd revert to the good old-fashioned descriptive term, manic depression. But for now, we're stuck with bipolar illness, and the result is that I see patient after patient who tells me they have bipolar illness and depression. The majority of patients I see who tell me they have bipolar illness do not. So what does it take to get a diagnosis of bipolar illness? Well, obviously, and based on the old name, the patient must have episodes of depression and episodes of mania. Bipolar illness is not moodiness, and bipolar illness is not disagreeableness, although during episodes of dysphoric mania, the patient may be disagreeable. Also, bipolar illness does not include constant abnormal moods. The patient will have spells of euthymia, normal mood, interspersed between episodes of depression and mania. When I get a patient who tells me they have bipolar illness, I immediately ask about symptoms of mania, because if the patient has never had a manic episode, they do not have bipolar illness. Now, a couple of things about mania. Today, bipolar illness is separated into 2 types. Bipolar 1, which is the old familiar severe depression and severe mania, and bipolar 2, which has equivalent depression but muted mania. In bipolar 1, the mania may become psychotic, usually with delusions rather than hallucinations. For example, a patient with no prior political experience may announce that they're going to run for president and win. That's clearly delusional. If there's psychosis, the patient cannot have bipolar 2 illness. Another common misconception is that bipolar mania is always happy. Sometimes it is. Sometimes it's euphoric mania, but sometimes it's dysphoric mania. We're all familiar with the fact that patients who abuse stimulant drugs such as crack cocaine or methamphetamine may become irritable, hostile, and paranoid. And the same thing can happen with the bipolar patient when they have an episode of dysphoric mania. Now here's the real pearl. Ask the patient this question: has there ever been a period where you got a lot done, had a lot of energy, slept very little, and did not feel tired? If the answer is positive, that's probably a manic episode. However, if the patient had an episode where they got a lot done, were very productive, got little sleep, and were exhausted, That's not mania. Other features that suggest a bipolar illness: number one, family members with a history of bipolar illness. Bipolar illness is the most hereditable of all psychiatric illnesses. Number two, a history of a suicide attempt. Bipolar illness carries the highest risk of suicide of all mental health conditions. Number three, a history of mental health related arrests, such as being arrested for causing a public nuisance or drunk and disorderly. Patients with bipolar 1 may get into trouble with the law during manic episodes. And number four, a history of substance abuse, either alcoholism or drug addiction. Bipolar illness carries the highest incidence of concomitant substance abuse of all mental health conditions, and I suspect it's due to patients trying to self-medicate their abnormal moods. So the second condition I'm going to talk about is spinal radiculopathy. Neck and back pain are the most common complaints of Social Security disability patients, and some will have clear evidence of radiculopathy, some won't, and some will complain of radiculopathy but exhibit impossible findings. So what are findings that are impossible in a case of spinal radiculopathy? Well, the first is complete numbness of an entire limb. You've all seen and tried to memorize those dermatome pictures, and you understand that a pinched or irritated or inflamed spinal nerve in the neck doesn't make an arm completely numb, and in the low back doesn't make a leg completely numb. Yet I commonly see patients who, when I do their sensory exam, will state that their entire arm or their entire leg is numb while they complain of neck or back pain, and that's impossible. Now, two things to keep in mind. Number one, spinal stenosis, which I certainly see with relative frequency in disability exams, can cause symptoms in an entire limb. And number two, we're currently in the midst of an epidemic of diabetes, and many people have diabetic sensory neuropathy, which presents in the legs most commonly, but also in the hands with stocking glove type sensory loss. So it's certainly possible that you may see a patient who has both a spinal radiculopathy and a diabetic sensory neuropathy. Now, the second feature in spinal radiculopathy that's impossible is weakness of an entire limb. Spinal nerves innervate certain muscles in the arms and certain muscles in the legs, but no spinal nerve innervates all the arm or leg muscles. And if all the muscles tested in an arm or a leg are weak, and the patient is stating that's due to spinal radiculopathy, that's impossible. The third impossible condition that I see very frequently is the patient who walks into the room normally, sits down normally, and rises from a chair normally, and then has severe 4 out of 5 weakness of the legs on physical exam. So 4 out of 5 weakness is the broadest category of weakness, and basically it means activity against resistance but reduced from normal. So it can be anywhere from a slight reduction to a marked reduction of strength against resistance. However, if a patient walks normally, sits down normally, and rises from a chair normally, they cannot have severe 4 out of 5 weakness in the legs. That's impossible. They're either exaggerating or feigning leg weakness. The fourth impossibility that I see fairly commonly is patients who complain of severe dizziness with no physical findings. In fact, sometimes it seems like every patient I see is dizzy. So here are the things to look for. Does the patient have a normal pulse? Severe bradycardia, severe tachycardia, and sometimes atrial fibrillation can cause dizziness. Does the patient have very abnormal blood pressure? Severe hypotension can cause dizziness. Does the patient have nystagmus, which would suggest a vestibular disorder? Does the patient display clumsiness with the arms and legs, or difficulty with the Romberg or heel-shin-toe walk, which I test in every patient who's capable of standing and walking? And finally, does the patient exhibit signs of postural hypotension? I don't normally test pulse and blood pressure in the supine and upright position, but fairly commonly I see a patient who, when they rise from a supine position on the exam table to a standing position, will tell me that they feel dizzy for about 10 seconds to a minute, and then the dizziness will clear up. And that's usually postural hypotension. If the patient exhibits none of those physical findings and complains of severe dizziness, that's impossible. The final two impossibilities are autoimmune diseases patients frequently complain of when they do not have, and the first is Sjogren syndrome. Sjogren syndrome is also called Sicca syndrome because it presents with dryness of the mucous membranes. A patient with true Sjogren syndrome will have dry eyes, dry mouth, or both. If the patient's eyes are normally moist and their mouth is normally moist, they do not have Sjogren syndrome. That's impossible. And then the sixth condition that I commonly see is patients who tell me they have rheumatoid arthritis when they do not. The clue is in the name. It's rheumatoid arthritis, not rheumatoid arthralgia. Rheumatoid arthritis is a condition of destructive inflammation in multiple joints. An inflamed joint will exhibit swelling, some tenderness, sometimes heat and redness, deformity, and stiffness. If the patient exhibits none of those findings in any joints, they simply don't have rheumatoid arthritis. In fact, while I'm taking the history, if a patient tells me they have rheumatoid arthritis, the first thing I do is glance at their hands. If the hands look normal, they probably have been misdiagnosed. Now, that's not to say that no patients that I see have rheumatoid arthritis. I've seen many patients in Social Security disability exams who have rheumatoid arthritis, some extraordinarily severe. For example, I saw one patient who had very large rheumatoid nodules, the size of walnuts in multiple extremities. And if a patient has evidence of destructive polyarthritis and nodules, they almost certainly have rheumatoid arthritis. Gout can cause tophi, but it's usually not in as many joints as rheumatoid arthritis. Now, I have a theory why so many patients are given a false diagnosis of rheumatoid arthritis. Patients with functional illness commonly have pain they describe as being all over or in all their joints. Patients with functional illness are desperate for a physical diagnosis. Not many people are going to feel sorry for you if you tell them that you have these vague aches and pains all over that no doctor has been able to figure out. But most people will feel sorry for you if you tell them they have rheumatoid arthritis. So these unhappy folks go to doctors, and sooner or later somebody orders a rheumatoid factor. As you know, low titer false positive rheumatoid factors are very common and increase with age. So sooner or later, a rheumatoid factor comes back positive. The patient is told they have rheumatoid arthritis, and they're delighted. Well, I hope this has been helpful. In my next talk, I'm going to talk about narcissism in disability patients. And always remember, if it happens, it's possible, unless it's impossible.